Good morning, everyone. I'm Raj Dave from Camp Hill, Pennsylvania, director of C3 course, and I welcome everybody to the next edition of Coffee, Cases, and Controversy, our very popular monthly series. Today, it's a privilege to have two distinguished guests. Dr. Colin Berry, who's the director of cardiology at University of Glasgow. He also is a director of research and consultant cardiologist at the Golden Jubilee National Hospital in Glasgow. He has most recently been a principal investigator of the Hyperemic trial, which is a very, very important study. And it's going to be the focus of the discussion today about how we manage our patients with non-obstructive coronary artery disease, what advice to give them, whether the chest pain is due to vasospastic angina, whether the chest pain is due to microvascular dysfunction, or it is a non-cardiac chest pain altogether. So I think that we're going to talk about CoroFlow software today to answer those questions and how we stratified the treatment, which was the fundamental principle of the Hyperemic trial. And Dr. Berry has the best view into the study, being a worldwide principal investigator for the study. Dr. Carlos Collet, who is my other distinguished guest today, who is a very well-known interventional cardiologist at OLB in Aalst, Belgium. He has a specific interest in coronary physiology as well as coronary CTA. He did his interventional fellowship at the Dante Pazzanese Institute of Cardiology in São Paulo, Brazil, and was also had additional training in Florida, and now working with Dr. Bernard de Bruin and Nico Pils, very good friends and award winners of C3 meeting in Belgium. So he's going to bring a very unique perspective into coronary physiology and has a very deep understanding of microvascular disease, as well as how to interpret and use CoroFlow software. So without further ado, I'm going to turn over to Colin, who is going to show us some cases. I think this is an extremely important exercise, given that there is a very high prevalence of non-obstructive coronary artery disease that we see in the cath lab all the time. And it's a challenge for cardiologists about what really to tell the patient and how do we treat the patient. Thank you very much for taking the time, Dr. Berry, and the floor is yours now.
So Raj, thank you for that introduction. I'm going to share screen and you'll need to tell me if you can see.
We see. Yeah. So if you go into the slideshow view.
Yeah, let's try this.
Yep, we see, great.
Okay, so thank you for the introduction. I'd like to first acknowledge my colleagues, Dr. Navalia Siddiq, who is a British Heart Foundation Clinical Fellow. She has led the CORE CTCA study. And I'd also like to acknowledge Dr. Margaret McIntaggart, who is a leading interventional cardiologist in the Golden Jubilee National Hospital. So the cases presented today gave informed consent to take part in the CORE CTCA study. And Dr. Siddiq in particular kindly helped to prepare this presentation. You'll notice that these cases have actually been published in the European Heart Journal case reports. So for those who are interested, you can go to that journal and you'll find this information in print. So chest pain without obstructive coronary artery disease, a case series report. And in line with the context to today's presentation, this is case-based. I'm not necessarily going to give information about the other background literature, but we can delve into that through the course of discussion. So, ischemic heart disease is, as many know, a leading cause of morbidity and mortality, especially in women. And ischemia with no obstructive coronary arteries, in other words, INOCA, displays a sex preponderance. We found in the Carmichael study that 3/4 of the patients who were enrolled in that study were indeed women. So the cases today, with that in mind, are all women. Even in those without obstructive coronary disease, women with angina continue to have increased mortality. And indeed, we could consider that ischemic heart disease in women, especially those with no obstructive coronary arteries, represents an unmet need. Gender differences are prevalent, and we must be mindful of the different pathophysiologies that may lead to angina in women as distinct from angina in men, where obstructive coronary disease is much more common. So that's the setting for the cases I'm about to share. The first case is of a 46-year-old lady, 6-year history of predominantly exertional chest tightness radiating to her left shoulder. She'd some morbidity, medical history of emphysema, depression, osteoarthritis, irritable bowel syndrome, including with prior investigations and previous cholecystectomy. But nonetheless, because of this history of chest pains, she'd been referred initially for a CT coronary angiogram and then on for an invasive angiogram. You'll see she exercised poorly. She only managed 3 minutes, 3 seconds on a Bruce treadmill exercise test, stopped through fatigue, but really that would be considered a submaximal test. Hence, she had a CT coronary angiogram, and this identified no angiographic evidence of coronary artery disease. So the lady was then referred for an invasive coronary angiogram. This was in the context of informed consent for the BHF Core CTCA study. The purpose of that study is to re-examine angiographic and physiological findings in patients with anginal symptoms, but no obstructive coronary arteries disease. In other words, where the CT scan has not provided an explanation for the individual's symptoms. So the focus of today is, shall we say, functional coronary angiography. In other words, the angiogram is accompanied by ancillary testing. And the format of the slides is this in the coming slides. So I'll perhaps take some time just to walk you through each of the components. So let's go to the angiogram first. We're most familiar with the angiographic images. And if you look to image B, you'll see smooth coronary arteries. It looks like we've got an EBU 3.5 French catheter sitting in the left main coronary artery, and the LED is smooth, as is all the way down distally. Then, if I may ask you to look to image C, and you'll notice with the free text on the right-hand side, this is consequent on acetylcholine testing. And this is revealing epicardial vasospasm in association with chest pain. And I would describe this feature as being a string sign. You know, string sign is actually a phrase taken from the surgical literature, but really highlights how the LED in response to approximately, this would be 100 micrograms of acetylcholine, for example, you can really see this kind of spastic string sign appearance. But what is helpful here is the presence of the coronary guide wire. You'll see the 30 millimeter length marker of a diagnostic pressure wire. And we undertake functional testing, and we introduced this phrase, an interventional diagnostic procedure. So this is including 2 components. It's including the diagnostic guide wire, and we'll shortly move to the upper panel, but it's also including acetylcholine. And this IDP was developed in the Carmichael study, and it was really done so to address the issue that many of the studies in the literature and even in clinical practice, the investigator will focus on one aspect but not the other. So they'll do acetylcholine testing, but they won't have a pressure wire or a Doppler wire. Or they may focus on the Doppler studies but not have acetylcholine. So we brought both together in our protocol, and that's what we do in our cath lab in the Golden Jubilee, wherever possible. So,
Colin,
yes.
one question. And for a case like this, that,
Yeah.
a lot of these people end up having stress tests, coronary CTA, etc.
Yeah.
One of the things that goes through my mind is that, a lot of these patients nowadays, there probably is no need for all that testing. You could probably go straight to angiography and do a functional coronary angiogram if there is no obstructive disease. If there is obstructive disease, we can certainly decide the physiological significance by physiological indices. So so that's one thought that occurs in my mind, that this might change our perspective on how to evaluate these patients in future. Second is that in the protocol that you are using in your lab, what is the chronology of testing? Do you get IMR, CFR, all those values first before you do acetylcholine, or what is the chronology of it?
Okay, so thank you for these questions. So actually our base approach is first the angiogram, then the diagnostic guide wire. In order to use acetylcholine, there needs to be some level of prior preparation. And we might want to spend some time considering that, but basically acetylcholine is not licensed for any use out with the eye. It's a mydriatic and it's used in ocular surgery, and that's its license, at least in the European Union. So actually acetylcholine is a barrier to functional testing, because if you tie in a protocol with acetylcholine, you really need to be well prepared for its safe administration. So for those who are online today and listening and in, how can I get there? I mean, my recommendation would be first get familiar with the diagnostic guide wire. In actual fact, the guide wire, we're using it routinely in the cath lab. It might be a conventional wire for angioplasty. This is what we do all the time. But then if we're considering measuring pressure ratio of whatever type, then of course we will use a diagnostic guide wire. And what's novel here is with this particular guide wire, pressure wire X, it's got an additional functionality that enables microvascular parameters to be measured. So these steps are well within the skill set of every trained interventional cardiologist. The acetylcholine is different. The acetylcholine needs to have some regulatory considerations and some additional training. But just coming back to your point, Raj, our first step would be the angiogram. Then, if felt to be clinically appropriate, we would reach for a diagnostic guide wire to measure CFR and IMR. And we would consider acetylcholine under, shall we say, special circumstances.
Okay, so this is part of the, Carlos, you are familiar with this software. This is part of the CoroFlow software, correct? So we can see everything on one screen, and this is the same guide wire that we are used to using for our current Abbott's pressure wire system. Is that all true?
Yes, it's the same software, it's the same guide wire. The only thing that differs from your normal, let's say, screen is that instead of going to the FFR module of the software, you go to the module that is called CFR IMR, which at the end of the measurements is the layout that Colin is showing you on the screen. If you go in detail to that screenshot, you will see there are several things going from top to bottom. The bottom of the screenshot shows a yellow line, which is the line of your pressure ratio. The part on the left side of the screen corresponds to the resting part of the measurements, which is divided by 3 white lines. These white lines are just showing you the 3 injections of saline that were performed in rest to get the resting mean transit times, which are depicted in the bottom part of the screenshot as blue lines. Then if you move in the same top screen a little bit more to the right side, you will see that the yellow line is a little bit lower because there is the hyperemic pressure ratio, in this case FFR, and you'll see that the value of FFR in this case is 0.91. Then you perform 3 additional saline injections. We do that typically with a 3 cc syringe. And then you get 3 thermodilution curves in hyperemia, which are the 3 curves in the bottom of the screenshot that are in orange or yellow. And the mean of these 3 resting in blue and hyperemic in orange transit times are shown there, and the values that Colin is showing there is 0.93 for the resting injections and 0.19 seconds for the hyperemic injections. And using these values, you will get your CFR, which is just the ratio of the rest divided by the hyperemic mean transit time, in this case 5, and your IMR, which is the multiplication of the hyperemic mean transit time, 0.19, times the diastolic pressure during hyperemia, which in this case is 62. So that is a bit of the explanations of the values that are being shown on the screen now.
So what are the normal values?
Well, typically for IMR, we use the cutoff of 25. The cutoff for CFR, you can discuss, but we can accept that a value of above 2.5 is normal for CFR. In this case, both the IMR, that is low, 12, and the CFR, which is high, are both normal, as Colin showed there on the screen.
So IMR should be less than 25? Is that, did I heard it correctly?
Yeah. Yeah.
Okay, so in this case, both were normal. So the next step would be to look for vasospasm, and that's why the acetylcholine was injected.
Yeah.
So in US, we have the same issue for acetylcholine that you have in European Union because it's available only as an eye drops. How do you mix the solution to inject inside the coronary?
Okay, that's a big question. So this approach has been well described. So first of all, I would recommend those who are listening to look to the literature, because actually acetylcholine has been used for this purpose for about 20 to 30 years. And there are a number of groups who have been doing that. And, you know, just before I go into to say what we do, I think it is acceptable to work with your local pharmacy to develop a protocol that is acceptable within your lab. It is the case that there are different protocols used for acetylcholine. They're all approximately similar, but this idea that one is better than the other, or, you know, you can only go this way. I think the message I want to convey to clinicians in this call is that you need to have a discussion with your pharmacy and work out what is the best approach for your cath lab. Go to the literature. There are a number of protocols published, and then decide what regimen works best. So what we do, we've got 2 approaches. So if we know that a patient has a clinical indication for a full IDP with acetylcholine, then we will pre-prepare solutions by arrangement with our pharmacy. We will order it through pharmacy. And then we will have 3 solutions in, I think they are 30 ml syringes, and we infuse 3 concentrations basically 0.18 micrograms per ml, 18 micrograms per ml, 1.8 and 18, 0.18, 1.8 and 18. And they are infused at 1 ml per minute over 2 minutes.
So I think this is very important for a lot of clinicians who want to use this software, because I think acetylcholine testing is an important part of this testing if we're going to go through patients like this who doesn't have obstructive state.
So let me stop you there. Stop you there. So the use of the software and acetylcholine are completely independent.
I understand. Yeah.
Yeah, and actually a take home from this discussion is, for those who are interested in this field, focus on the guide wire first. Focus on using tools that we're familiar with already and get into the habit of measuring IMR and CFR, or there are other vendors that could be used, the combo wire. You can get HMR there. And that brings a lot of information. The acetylcholine is a separate discussion. It's important, I recommend it, I support it, but we want to see coronary physiology disseminating into the cath lab. And acetylcholine has some special considerations and should not hold up, shouldn't impede the diffusion of those simple techniques which are we already familiar with the guide wire.
There is a question from our attendees today. There's one question that says, can you go through how you clear the guide before you inject the saline?
Well, typically what we do is the following. So first you start setting up your coroventis, and the same as you do for the pressure. When you try to do FFR, you have to put the pressure sensor in the tip of your coronary catheter. You equalize the pressure, so you have a button in the start to equalize the pressure. Then you advance your pressure temperature wire to the distal part of the coronary, and when the wire is parked in the distal part, you kind of perform an equalization of the temperature. This is called zero temp. It's a button that will appear in the coroventis screen. After this step, then you prepare your syringe, that typically again is a 3 cc syringe, and you perform your 3 injections in rest. And these again are the blue lines that you'll see there. After you finish your 3 injections in rest, you induce hyperemia. This can be done either by IV adenosine. We in ALS use intracoronary papaverine. Regadenoson is also an option. And when you are in hyperemia, you perform again 3 new injections. And these are the injections that you see in orange. How do you clear your catheter? With normal saline. Just flush before you perform these injections. And there is a trick that we normally see. If one of the injections is not perfect, and you will see that clearly that the shape of your temperature curve is not exactly the same as before, that can happen either because the catheter fell a bit from the ostium and then not all the 3 cc of saline went inside the coronary, or maybe you are not in full hyperemia in that moment. You just can replace that curve by clicking on top of the curve that was not as good as you expected and just inject again. And when you have 3 curves that you are happy with, then you finish your study and you get this screen that is showing in the slide.
That's fantastic. Well, that was a lot of important issues that were discussed here, and how to clinically actually put this in action in the lab. So what happened in this case, Colin? This is clearly a vasospastic angina patient. You are on a mute, I think.
Yeah, sorry about that. So this is a clear diagnosis, and there's an indicated therapy. Calcium channel blocker with use of GTN spray may be helpful. Now, beta blockers are widely used in ischemic heart disease. And in our experience, patients are coming through the the outpatient clinical pathway and they've been managed for angina of an uncertain cause, beta blockers are the first line treatment. So we usually find patients who have this response to acetylcholine commonly are taking a beta blocker. So we'll change that beta blocker to a diltiazem or sometimes verapamil. Actually, there's evidence, there's a nice paper in the New England Journal favoring, I think it's nifedipine. So I think, you know, we would default to diltiazem, amlodipine, or verapamil rather than nifedipine, because I think nifedipine is also associated with escape effects on tachycardia and so forth. So I'm not prescribing nifedipine. I am prescribing diltiazem, and I would start at a low dose. Actually, I had a patient yesterday, and we spent a long time talking about changes in our therapy. And usually what I do is my initial purpose is to ensure that the treatment is tolerated. Because if you start a treatment and the patient can't tolerate it, you know, you've achieved futility. So, you know, diltiazem might be prescribed as once, twice, or 3 times daily. It might eventually go as a long-acting medication, but, you know, I prescribed it just 60 milligrams once a day for like 1 to 2 weeks, just to make sure that it agrees with her. And then she can go to twice daily. Then she can go, you know, maybe in a month's time onto a long-acting preparation. And I find that sort of personalized approach tends to be more successful in patients being compliant with treatment.
Now, the treatment compliance is very, very important. And I see that with lots of different therapies. We are working on some of the treatment for hyperlipidemia in US and in Medicare population. One of the major obstacle is the treatment compliance for these patients. So I think that's very important. Well said. You know, I think lots of options, but diltiazem obviously very well tolerated, and then sublingual nitroglycerin. Okay, well, let's take a look at the next case.
Okay. So the first observation I would make is look at this lady's age, only 42 years old. She has a 2-year history of typical anginal symptoms, Canadian Cardiovascular Society class 2, so she's getting effort angina. Again, anxiety, depression. She's taking propranolol for her anxiety, but she's an ex-smoker. She's clinically obese and migraine. So she's got some risk factors like our first patient. Again, like the first patient, an exercise test. In this case, this lady managed 6 minutes, 23 seconds. So that is getting closer to, you know, the expected workload that might be achieved on a Bruce protocol for a woman, because the predicted exercise times differ for men and women. And she stopped though, not because of chest pain, but she stopped because of breathlessness and fatigue. But she did report chest pain at 4 minutes, but without ECG changes. So I think this is like a classic type of, you know, report from treadmill exercise testing in a patient like this. But again, like the first patient, you undertake a CT, coronary angiogram, smooth coronary arteries. And
You'd be surprised, but you know, this is such a common occurrence in the cath lab for us, at least in US. And Dimitri is smiling from Greece. Dimitri, isn't this a very classic, you know, at least once a week, I think I come across one of the patients like this where, you know, they have an abnormal stress test, you know, have chest pain, might have some risk factors. They come to the lab and the arteries are okay, and we don't know what really to do with her.
That's correct. That's absolutely correct. And that's why I'm smiling. Absolutely. We see many patients every week having these symptoms, normal coronary arteries. We tend to call these patients as the lunatic patients. So it's something like psychologic, or sometimes we give them some, you know, therapy, which is only symptomatic. It's indeed, we don't know what to do about this patient. And now I can see we have a great option here. We know we do a couple of these patients, a lot of those patients, I would say, see CFR with the echo. But this, it tends only to be specified to the LAD. We give of these patients a lot of vasodilations with the echo probe. We can identify the LAD. We do some CFR for those patients, but this is the option. I think this is the right thing we have to do. And thank you very much for giving us this.
From my perspective, this is going to change the examination paradigm, because we can simply go straight to angiogram, so that if angiogram shows, negative a CAD for negative for stenosis, then we can go straight to the functional testing and can have an answer for the patient, whether it's in her head or whether it's microvascular or whether it's a vasospastic, which we could not do before. And, I don't know what we might have, called them, that we just don't know what the result is. So I think, Colin, this is really going to change, the future paradigm of investigation for these type of patients. And that's why I think it's very important. So let's see what we found on this case.
Okay. So as mentioned earlier, it's the same format. So probably the right thing is just to look to the angiograms first. I'm sorry that I'm not showing cine angiography. I can pull up other cases with if needs be, but that would need to be to come out of this PowerPoint. So let's just carefully examine the angiograms first. So again, you'll see this 5 French EBU 3.5 catheter. The coronaries are smooth, difficult to appreciate with this relatively small frame size, but I hope you'll accept they're smooth coronaries. Then again, having the diagnostic guide wire in situ during the acetylcholine testing, it's helpful for a number of reasons. Well, first of all, it serves as a landmark, and you can see that disconcertingly, there's a loss of flow in the LAD. And let's just look at this in a little bit more detail. So you'll see that the caliber of the LAD is well maintained up until that diagonal branch, and then it's basically chopped off. So, and that is explained from a physiological perspective by severe, complete microvascular spasm. There is just complete loss of flow in the distribution of the LAD due to microvascular spasm. Now, we can't see that. That's a limitation. But nonetheless, that is what explains the feature of the LAD as distinct and compared to the first case. The first case, there was this kind of string sign feature. Here, the angiographic appearance is completely different. And it's disconcerting, don't get me wrong. No one would wish for this type of appearance.
But I'm just the patient's complaining. Yeah, and
exactly. Yeah. Well, I mean, and I know Carlos is involved in these procedures as well. We have patients in the cath lab, and this happens, and they say, "Oh, doctor, that was the chest pain that woke me from sleep on Monday night." It's this kind of, these atypical chest pain reports that you would never consider as being, anginal in nature. I've literally had patients say during this type of angiographic appearance, "Oh, that's the chest pain I get." And then you look at the angiogram and you've got to think, oh my goodness, what is going on in the coronary circulation of these patients when they're experiencing chest pain? And importantly, therefore, this takes us into, the term provocative. This isn't my term. This is, as I say, this technique has been established for many years. This is provocative testing, but it's under controlled circumstances in the cath lab. And the half-life of acetylcholine is vanishingly small, like less than a second. It's a natural neurotransmitter. And for us, so our protocol, we run an infusion. So we discontinue the infusion immediately, and we administer, if needs be, GTN spray. And without exception, in my experience of several hundred cases, this appearance reverses immediately.
So you said GTL spray.
Sorry, GTN. Well, yeah, it could be. Yeah, it could be spray or it could be intracoronary GTN. Excuse me. Either is not.
So in this case, Colin, I think it's very nice because we see this, and I have to agree with you. This is it's typical from young women that you see with a typical chest pain. Then you go to the cath lab and you see the ECG while you infuse acetylcholine, and you see a huge ECG changes. Look at the T way at the ST segment in the inferior wall there. You see a clear ST depression compared to baseline, and the patient experiences the same symptoms. And that is typically the case of this microvascular spasm, as Colin mentioned.
In actual, how do you interpret the IMR and CFR
yes, yeah,
in this type of situation?
Right. So just to highlight again that different labs have different protocols. And again, I would like to emphasize, for me, that's okay. You know, each lab has got to do what works best for them. So in our lab, we do the angiogram, then we do the guide wire study with FFR, IMR, CFR, and then we do the acetylcholine. Today, I've talked about the acetylcholine first because it links with the angiogram, but actually the order is angiogram, guide wire, and then acetylcholine. So yeah, I can, Carlos eloquently described the features in the previous case. I'll do the same if that's okay. So first of all, let's just see the headline results. The IMR is 24 and the CFR is 1.7. So abnormal is 25 or higher. So this is very borderline. But let's remember, this is a biological trait. So a true normal is 12, 14, 16. You know, this value of 24, if we take a binarized approach to decision making, this could be classified as being normal, but it really is in the borderline of being abnormal, and it's high. And in terms of reproducibility, you know, it's possible that this could be 25 or 26 on repeated testing. But what is very clear is that the CFR is low at 1.7. And normal CFR is like 3, 4. So this is markedly impaired. And the IMR and CFR, they represent different functionalities of the microcirculation. So they're not interchangeable. And IMR is resistance and CFR is vasodilator reserve. In this case, responds to an infusion of adenosine. So you can have normal in one and abnormal in the other, or abnormal in both. And then if we just go to the Coroventus readout, sorry, just trying to activate the cursor here. I don't know, can you see the cursor when I'm moving it or not?
No, we are not, but.
Okay, can you see it now?
Now I see it, now I see it.
Okay, right. So we know the angiogram's normal. Interestingly, the FFR is 0.91. Then I'll just walk you through the readout. So we've got, there's the aortic pressure, 75 divided by 82 gives 0.91. We've got the resting measurements, and then we've got the CFR. So this value of 1.7. So let's just come down to the thermodilution page. So if we are focused on pressure-derived ratios, we will have only that. It depends on how the screen is enabled. But if we are enabling for thermodilution, well, first of all, of course, this lower panel is going to be blank. So I just want to kind of convey to you that with each injection of saline that is recorded, you will accrue progressively the curves. So you start from a black screen, then the first curves are at rest in blue. So you're going to start with 0.53, 0.58, 0.53. And in this case, you know, the shape of the curves, they are overlapping, and also numerically, they are closely approximated. And the average value is 0.55 seconds. So that is the time, the thermodilution time. The y-axis is temperature. So with the saline going in, let's say 18 degrees, this is the reduction in temperature that is detected down here, because that's where the thermistor, pressure and temperature sensor, is present. And then following 3 repetitions, the adenosine or papaverine is administered. In our case, it's intravenous adenosine, 140 micrograms per kilogram per minute, as you would do for FFR. And there's a clear left shift, but still the curves are overlapping. So again, in fact, the hyperemic curves, the values are fairly closely approximated also, 0.34, 0.33, 0.29, the average is 0.32. And the derivation of CFR is 0.32 divided by 0.55, sorry, 0.55 divided by 0.32, at rest divided by hyperemia. That's where the 1.7 comes from. And as Carlos mentioned, IMR is during hyperemia, the distal pressure multiplied by the mean transit time. So 24 is derived from, it's going to be 75 times 0.32. Now previously, when we had the radioanalyzer, these values weren't displayed on the screen. You literally had to calculate it in your head or ask one of your colleagues to calculate the data. So it's great to see the advances in the software, that the thermodilution curves are nicely displayed. The numbers are automatically calculated. As Carlos said, if you're not happy with, because this is manual and the technique does have imperfections, that's for sure. But if you're not happy with one of the thermodilution values, like it's obviously outlying, you've got 0.34, let's say it was 0.57 and the next one's 0.29, well, clearly the middle one is outlying, so you can highlight that and then inject saline again. And you're looking basically for concordance. You're not trying to shape the result in one direction or another. You're just looking for reasonable concordance in the numbers. So
sorry to interrupt, but this is a very important point that you're making there. And if you don't have concordance, or your first injection provides you with a mean transit time that is very different from the second injection or the third injection, you will get a yellow box around your numbers. And this yellow box is actually a warning of the system, of the Coronary system, telling you there is higher variability than expected. Look at your values and replace the one that you think is the outlier. So the system kind of help you to get, let's say, concordant values when you're doing this resting and hyperemic injections.
Yeah, thanks for highlighting, Carlos.
Carlos, you have a video of how to acquire IMR. Is it ready? You want to show it?
Yeah, sure.
This sounds like a great time to do it.
Perfect.
Yeah. So I'll stop sharing. Over to you, Carlos.
Okay. Let me just. I think. Can you see my screen now?
Yeah. Yeah.
Yes.
We see.
Yeah. Let me see if I go full screen. And okay. So I will put the audio and I will do the comments here by myself. So here we're in the lab. We're just preparing ourselves to do these injections. Sorry for that. And this is the normal setup. So we can do radial, we can do femoral, that's up to you. In ALS, we do first the acetylcholine injections, and then we move to the IMR and CFR. So look, the setup of the manifold is important. So the way we do it is that we put a 3 cc syringe again. We put that at the end of our manifold. And the idea will be that this syringe will help you to do standard injections and help you have the similar force in your injection and making your thermodilution curve look similar to each other. So normally we flush the system, the guide wire is already inside the coronary, and here you will see the setup of the coroventis. It will come on the screen. Let's, and this video actually is going to be available for educational purposes as well. So this is how we do it, right? So we go from the FFR to the CFR IMR mode, we click there, and then you see that this layout appears. We zero the temperature. This is the practical step, zero the temperature. And as soon as your temperature is zero, you'll see in the right side of the panel called temp is 0.00. That means that you're ready to start. So when you're ready to start, then you prepare to do the first injection. And this is how it works. We do 3 injections of saline, and you see that I'm going to do the first injection, and look what happened in your monitor. You'll see the decreasing on the temperature curve. You see that the blue temperature is the thermodilution curve at the distal sensor. The mean transit time there is 29. Then comes the second mean transit time, which is 0.31, looks like the first one. And then I do a third injection and I'm still in rest. And then I got my third transit time, and this is 0.29. Look, so this is pretty nice. Then I am ready to go for my hyperemic injections. In this case, we use IV adenosine. We wait a couple of minutes to be sure that we are fully in hyperemia. And then I start again the same 3 injections, but now during hyperemia. So I just click on the button that says induce hyperemia. This is a trick. I normally flush 2 times because in the meantime, the saline in the catheter might be warm up because of the blood in the patient. So I flush a couple of times to be sure that I have, let's say, room temperature saline in the line. And now I am prepared to do my 3 hyperemic injections that are going to be used for the calculation of the CFR and the IMR. So we click on the button induce hyperemia, first injection, second injection. The system will tell you inject now. So you see that the system tells you wait, don't inject don't go yet with the next injection. Now inject now, and you make the third injection, and then that's it, right? You see, it took not a lot of time. Here I have some high variability, so I decided to repeat one of the measurements, and this is what I'm going to do now. I replace one of the measurements with an additional injection, and then I get 14, 12, and 14 again. And my IMR, if I see the screen, is 0.11. I'm sorry, with a CFR that is also 2.0, a little bit low. So this is a bit from the practical point of view, how we do it, these 3 injections in the cath lab.
Seems really easy to me that, once you do your first 3 and then adenosine and then the next 3, and you should get the reading.
Yeah, that's it. That is.
And then, because the adenosine is already running and you have a pressure wire already in the coronary, you should also automatically be able to get your FFR value at the same time.
Yes, you get your resting, you get your PDPA, your FFR, CFR, and IMR, and it really takes you about 5 minutes to do the complete measurement.
In US, I think that, we do need to work with the company to have a new code for this testing. We have the billing code for functional physiological testing, but I think we need to have a more comprehensive code to accommodate, the more time which is spent and the more equipment and the drug which will be introduced. So I think I'll definitely talk to Abbott about that. Because I think it'll be important for CMS to recognize that, and the other insurance company also follows that. Because I think that's gonna, I don't want physicians to be disincentivized because there is no reward for their work. Yeah, which I think.
Raj,
yeah,
that's exactly why we gave this term interventional diagnostic procedure, because as we heard earlier, usually when the angiogram's normal, procedure's done, that's it. But actually, we want to empower interventional cardiologists not to stop, but to continue with the diagnostics. And so this IDP concept, that could exactly track into a code, a reimbursement code, to underpin the rationale for continuing with using additional kit and spending additional time in the cath lab, because at the end of the day, a patient you would only want to have one angiogram in your life if possible. And really, the patient should be leaving the cath lab with a correct diagnosis at that time.
No, I cannot agree more, because I think that, for these type of patients, this is the way to the future, because I think this is how we identify, what, may be the best treatment strategy. And in some patients, maybe there is no treatment strategy because it may be, completely atypical. But I think this will definitely answer the question. Anyway, so now we can go back to your case, to see what was the inference of the testing and what was done.
Okay. So
this is a great, example of microvascular spasm and reduced coronary vasorelaxation, where you have a complete obliteration of the vessel.
So you can see that we've again gone for a calcium channel blocker, in this case verapamil, but we've also prescribed a statin. Surprising that, given a history of anginal symptoms for 2 years and transitioning through the outpatient clinic setting, she wasn't prescribed a statin. And then during follow-up at 4 months, so Seattle Angina Questionnaire, physical limitation, 55. So that's out of a scale of 100. That is markedly depressed, 55. And at 4 months, it has self-reported to now be around 72. Only this is one report, and we need randomized trials to look at this, and actually that's what we've done in the Carmichael study. That's exactly what we did. But at least in this lady's case, she appears to have gained some benefit, but still some symptoms, of course.
But better than before.
Better than before, definitely. In actual fact, pharmaceutical treatment on its own is unlikely to, shall we say, cure the patients. We know from this patient's, there was some psychological morbidity, there was obesity, and angina. So I do think, achieving a lower BMI is going to improve well-being, and that in itself can improve one's self-esteem and confidence. That can improve the psychological morbidity associated with chronic angina, and then the medication itself may be helpful. And so really the health and well-being of the patient at a holistic level will improve through a number of measures, and exercise as well, any dietary considerations. So it's all of these things. I think to prescribe and expect that in itself, it's not going to be sufficient. You need to think about the whole patient.
So we have about 10 minutes left, Dr. Berry. If you like, maybe you can show one more quick case, and we make some final comments before we let everybody go to enjoy the weekend.
So you advised to go to case 4 as opposed to case 3.
Yeah.
Okay, so let's just move through to case 4. 51-year-old lady, 9-month history of exertional chest pain radiating to the jaw. No past medical history. Exercise test, duration 6 minutes, 22 seconds. So she's done well. She's approximated what an exercise achieved exercise time, but she stopped due to limiting chest pain. In actual fact, the chest pain came on in the first stage of the Bruce protocol at 1 minute 23 seconds, but again, no ST segment changes. CTCA, plaque in the proximal LAD. So again, the same format. This time the angiogram is in the upper panel, so that's good. Let's look at the angiogram. So looks like a dominant right coronary artery, somewhat tortuous, but certainly smooth. Left coronary artery, again, tortuous, but smooth, all vessels. So now if we, since we've got the data here, the IMR is 41, that's very clearly high, and the CFR is 1.6, it's very clearly low. In actual fact, the acetylcholine test responses were all entirely normal. So in the interest of time, I've just given you that headline statement, and I'll just pass a comment here. So, I've given presentations in this subject for several years, and a question often comes to say, look, acetylcholine, I bet if I gave this to any patient, they would have an abnormal response infusing acetylcholine. And that is not the case. So in the Carmichael study, there were 18 patients out of 151 that had true normal acetylcholine test responses and normal guide wire. They had non-cardiac chest pain. So this diagnostic procedure is useful to, with confidence, exclude disease and assign a diagnosis of non-cardiac chest pain. In this patient's case, the acetylcholine was totally normal, but there is an abnormality as revealed by the guide wire. So the IMR is 41, and you will see the values on the Coraventa screen. And then, since we spent some time discussing this already, you'll see the white lines for the injections. If we just come down to the resting curves, 0.84, 0.88, 0.99, again, the times are fairly concordant. You'll see that the curves don't appear quite so concordant, but in actual fact, the magnitude of the displacement and the time course is fairly similar. What's different is like the onset and the exponential fall in temperature, which is slightly different, but the actual transit times are very similar. And then following the introduction of adenosine, there is some shift to the left and increase in flow velocity reduction in time, but it's insufficient to achieve a normal coronary flow reserve. And with this averaged hyperemic transit time of 0.54 multiplied by the distal pressure 76, you get an IMR 41. So this is clearly elevated. This is microvascular dysfunction attributable to what we say is structural remodeling, whereas with CFR, if it's impaired, that would be functional remodeling. So structural or functional or both, in line with the results of the tests. To treatment, we've diagnosed microvascular angina due to impaired vasodilation with the low CFR, high microvascular resistance, 41. In actual fact, the treatment here was appropriate. We gave no changes. I'm sorry, I don't have a list of the medication to give you, but sometimes no changes need to be made. And I'm just, I suppose, highlighting that this patient was actually taking part in our clinical trial, which is looking at the value of physiological testing in this patient population.
No, what would be a treatment in a case like this if the patient was not on anything?
Right, so I would again, so if there is vasospasm, microvascular vasospasm or vasospasm of the conduit coronary artery, the angina medication of choice would be a calcium channel blocker. So in this case, I would be prescribing, as in previous cases, diltiazem or verapamil. If the IMR was increased in isolation, so you've got a high IMR and a normal CFR, then it would be reasonable to prescribe a beta blocker.
Yeah, that's an important distinction, right? So if you have high IMR but a normal CFR, beta blockade is the choice.
That's reasonable, yes.
Carlos, any thoughts?
Well, so I think that one point that was Colin went fast and we went into the cases themselves, but in every case, there was a CT performed beforehand. And
Yes.
this actually is extremely important from the logistic point of view, because when the patient comes to the cath lab, you are already prepared to do your microvascular measurements. The acetylcholine is prepared. So it's not a surprise, the fact that the patient has normal coronary arteries. And this facilitates a lot the logistics in the cath lab when you already know what you're going to do and you have all these drugs prepared.
Raj,
Great thought.
Raj, if I can ask two quick questions, very quick. I know it's going to be negative, but I would like to ask for practical reasons only 2 questions. Thank you very much for this great presentation. I think we all have to study once again the coronary physiology. First of all, in case we have a proven microvascular dysfunction, can we administer this patient, let's say IV or intracoronary diltiazem or verapamil, and repeat the exam again in order to identify whether there was a positive response, I would say?
That's a good question.
Yeah, so that's a great question. And we are looking at this in our cath lab. But first of all, there's no clinical trial to support that strategy. And for that approach, the clinician really needs to take responsibility. It might be reasonable, but it needs to be carefully considered in terms of, you know, if you're giving intravenous calcium channel blocker and the patient is already taking a beta blocker, you know, there could be some important effects on depressing heart rate and blood pressure there. So that approach, I support in principle, but safety is a very important consideration, and prolongation of the cath lab procedure as well.
Okay, thank you very much. Second quick question. For practical reasons, we usually administer adenosine in intracoronary, you know, most of us do this. Can you think that we can take the same physiology examination within the 30 seconds, I would say, adenosine fraction? Or I would say, okay, given intravenously, it's the best way, but can you think that I saw the video and I saw that it's really quick to take the measurements.
Carlos, would you like to take that?
Yes, sure. So there is a recent paper describing how to use intracoronary adenosine in the context of bolus thermodilution measurement. So it would mean that you will do an intracoronary administration of adenosine, then you do one injection with saline, then you do another time adenosine. So you will need to do 3 times intracoronary adenosine and 3 times the injection of
okay.
It's feasible. Yes, it is.
Perfect. That's really good because it's more practical. And if I take advantage of the experience of the 2 great speakers, my PhD is on reperfusion injury, so I worked a lot in reperfusion injury. And we used to do, but this is anecdotal experience, but we used to do in experimental animals, acetylcholine provocation test in the non-carotid artery for myocardial infarction. And the thing that we saw was that even the normal, let's say, right coronary artery had a severe vasospasm after the reperfusion of, let's say, the LAD. Do you have any experience of this in humans, or do you think that we're trying to do this in humans, but you know, it was really, the safety was a real concern in this case. So we didn't manage to pass the protocol through the ethical committee. Right. So do you have any experience?
So there are a couple of publications from Filippo Cria's group and Udo Sechman, Peter Ong, so that's in Rome and in Stuttgart, of acetylcholine testing in Minoka patients.
Mm-hmm.
That's an area of interest.
Okay.
Well, thank you very much, Dr. Berry and Dr. Collet and Dr. Nikas for your very valuable time. We're up on the time here. I want to thank all our attendees. We have a very, very wide range of attendees all the way from US to Malaysia and Indonesia. Lots of people on our Facebook Live from all over the world, including China and India and Japan. So I want to thank everyone. I know it's late in other parts of the world, so good evening to everybody out there. Look forward to having you again for Coffee Cases and Controversies on April the 10th, which will be our next show next month. Have a great weekend. Thank you very much.
Thank you very much.
Thank you, Raj.
All the best.